Okay, we're going to talk today about A&P of normal skin and soft tissue. That's going to be the basis for looking at skin breakdown, for looking at wound healing and wound management. So looking first at just general characteristics of the skin, a lot of this is what you already know. You already know that the skin is the largest organ system in the body, and I'm sure you all have an appreciation for how important the skin is. I think many times in clinical practice it's easy to overlook the skin because it doesn't seem nearly as important as the cardiovascular system or the renal system. But it does play a critical role because it is the one organ that creates a barrier between the internal environment and the external world. It's the only barrier we have to bacterial invasion, fungal invasion, viral invasion, so it's obviously very important to keep the skin healthy. So that brings us to the next point. What are the characteristics of healthy skin? We should always keep these in mind when we're selecting products and when we're setting up skincare protocols. And as you see, the first characteristic of normal skin is that it's dry. Now clearly we don't mean dry as in cracking. We mean dry as in not wet, not macerated. You've all seen patients who have overhydrated skin who are diaphoretic, and you know that they're very vulnerable to breakdown with minor trauma because overhydrated skin loses tensile strength and breaks down very readily. In addition, overhydrated skin drags against the underlying linen, and that again increases the risk for breakdown. But the second thing we have to look at is we want the skin to be supple. So we do want it to be dry, as in not wet, but we want it to have normal elasticity, normal give, normal resilience. And skin gets that normal resilience from being moisturized. And we'll come back to that in a few minutes. We'll talk about the importance of that. And finally, we want to keep the skin in its normal pH range, which is slightly acidic. As long as the skin is slightly acidic, you have a barrier to bacterial growth, fungal growth, viral growth. So when we're selecting products for routine skincare, when we talk about products that are pH balanced, what we mean is products that maintain the skin in the acidic range. Now the other thing you'll notice is that on the slide you have a brick wall. And that's because we want you to think of the skin as having a brick and mortar configuration. When we talk about a brick and mortar configuration, you think of the skin cells as being the bricks, and you think of the skin oils as being the mortar. Now going back to the brick wall analogy, you know that the mortar is just as important as the bricks, because if you chink away all the mortar, the brick wall will fall down. When you take it to the skin, if you remove a lot of the skin oils that normally fill the gaps between the skin cells, then that creates gaps that allow bacteria to penetrate, allows irritants from stool and urine to penetrate. So very important to maintain the cellular structure and cellular hydration. Equally important to routinely replace skin oils so that you have an intact barrier. And when we talk about the barrier function, what we mean is that you have cells that are normally hydrated, because cells that are dehydrated shrink, cells that are overhydrated swell. So you want cells of normal contour, and you want all the gaps between the cells filled with either oils that are produced by the sebaceous glands or oils that are provided through moisturizers. As long as you have that, you have an intact barrier that presents a very effective defense against anything that wants to get through. Now, I'm going to just mention this. We're not going to test you on this, but when you're reading research studies about skincare, you'll frequently see the term TEWL, which stands for transepidermal water loss, and that's actually a measure of the skin's barrier function. When you have that intact barrier, water vapor can pass through the skin, but at a very slow rate. But when the barrier function is compromised, when all of those skin oils are lost, then obviously moisture vapor can pass through the skin at a very rapid rate. So as the barrier function deteriorates, the TEWL levels rise. And I just wanted to explain what that means. And then the last thing you see on your handout under general characteristics is the thickness of the skin. When we talk about the skin, we're talking about the epidermis and the dermis taken together. And normally the thickness of the epidermal and dermal layers is right at 2 millimeters or 0.2 centimeters. That gets to be important when you get into staging. Those of you who have been involved in doing pressure ulcer staging know that it's very difficult sometimes to differentiate between a stage 2 and a stage 3 wound. If you know that the normal anatomic thickness is 2 millimeters, that can help you, because if the wound is 3 millimeters deep, it's probably a stage 3. It probably goes past the dermis into the subcutaneous tissue. On the other hand, if you have a wound that is 0.15 centimeters, then the likelihood is that it is confined to the skin layers themselves. So in summary, general characteristics, your skin plays a critical role. It creates that barrier between your internal environment and everything in the outside world. Healthy skin is dry, supple, and acidic. And we never want to forget that brick and mortar configuration. Specifically, our goal is always to keep the cells hydrated and the gaps between the cells filled with moisturizers or naturally produced skin oils. So now we're going to look at the anatomy of each layer of the skin and soft tissue. We're obviously going to start at the top, the epidermis, the outer layer of the skin. That's the layer that has the barrier or creates the barrier. Normally the epidermis is about 20 cell layers thick. That's in a healthy adult. 20 cell layers is very thin because you think each cell layer is microscopic. Now when you think of patients you've had who have had skin tears, when you think about when you get a sunburn and the epidermis peels off, if you've gotten a blister and you look at the thickness of that blistered layer when it peels away, very thin. And that's in you, a healthy adult. If you were elderly, if you were very ill, your skin would be even thinner. Now looking at the sublayers, there are actually 5 sublayers and they're all listed on your handout. And I'm not going to go through every single one of them. I want you to focus primarily on the bottom layer, the stratum germinativum, and the top layer, the stratum corneum. And I actually want you to start with the stratum germinativum. And I'm going to show you right here where that is. It's this layer right here. Okay? It is a single layer of actively dividing cells. And it's the only living, actively dividing cell layer in the epidermis. Cells are produced at this level, and then they start to migrate upward. And as they migrate upward, they undergo a number of changes. They lose the DNA, which means they become non-living and incapable of reproduction, so only that bottom layer is capable of reproducing. And they also become filled with keratin, which is a tough protein, so that by the time they reach the skin surface, the stratum corneum, they're like little dry but waterproof shingles. And they sit at the surface of your skin just like shingles sit on the roof of your house. And they protect you. They keep everything pathogenic out. They keep irritants out. They keep fluids in. So you think of the lifespan of a cell. Cells produced in that stratum germinativum migrates upward, undergoing a number of changes, gets to the surface, sits on the surface for a period of time providing protection, and then is sloughed off and replaced with cells that are arising from below. Now, what else do you find in the epidermis other than those keratinocytes or epidermal cells? Well, you have melanocytes. And melanocytes are the cells that give each of us our unique pigment. You also have a number of nerve receptors, and you think how exquisitely responsive and sensitive your skin is. You can detect a slight breeze, light pressure, deep pressure, heat, cold. Your skin is extremely sensitive. And that, again, is part of your protection, because you need to know when you're being exposed to heat, when you're being exposed to cold. There's another feature known as the Reed ridges or Reed pegs, and it's the feature that allows the epidermis to dip down into the dermis and create an interlocking effect. So these projections in the dermal layer are called dermal papillae, and then the protrusions from the epidermal layer are known as Reed ridges or Reed pegs. Together, they act much like an interlocking puzzle. Gives your skin much greater strength, because when you pull against the epidermis, you're not pulling just against the dermis, or excuse me, not just against the epidermis, you're also pulling against the dermis and even the subcute. Unfortunately, newborns do not yet have this interlocking configuration, so they're very high risk for skin tears. And the elderly lose that interlocking configuration and become very high risk for skin tears. Notice on your handout, another feature of the epidermis, no blood vessels. Well, you don't need blood vessels because you only have one single layer of actively reproducing cells. The rest of the cells are dying or dead, and they don't need blood vessels. Well, what about oxygen and nutrients needed by that bottom layer, that actively reproducing layer? That's supplied by all the blood vessels in the dermis. So you have a rich blood supply for that actively reproducing layer, but you have no blood vessels in the epidermis itself. And that's why when you get a blister, when the epidermis separates from the dermis, it's clear, because there are no blood vessels. Also, you see on your handout that you have a skin immune system. So the primary protection provided by the skin is that barrier function that just keeps everything out. But you also have a number of immunocompetent cells within the epidermis and dermis that stand ready to protect you should there be a breach in the skin's barrier. So you have mast cells, which release histamine. You've got lymphocytes that can actually process antigens, and then you've got your Langerhans cells, which actually present antigen to the T helper cells. Take it all together, though. What's the primary function of the epidermis? Protection. Primarily through that barrier function, secondarily through the skin immune system. Now we're going to the dermis. The dermis is by far the thicker layer of the two skin layers. I'm actually going to go back a minute because I think you can see it more clearly here. So here's the thickness of the epidermis, not thick at all. Here's the thickness of the dermis. So you see that most of those 2 millimeters, those are the dermis. Now, what are the key structures in the dermis? When you read anatomy and physiology of the skin, they'll always talk about the papillary dermis and the reticular dermis as if they're two distinct layers, but they're really not. The papillary dermis is the section of the dermis that has this rich network of capillary loops, also known as the dermal papillae. So the upper layer of the dermis is known as the papillary dermis. The lower portion of the dermis is known as reticular. Not critical. You don't have to know that. We will not ask you that. We will want you to know about the key cells and the key structures in the dermis. So let me first just talk about the key structures. What is the dermis made of? Well, primarily collagen. And you will sometimes see wounds that extend into the dermis and they'll look kind of pale white. They'll have distinct little red islets scattered throughout, but the base of the wound will look white. That's because the dermis is primarily collagen. The dermis also contains elastin, which is another type of protein. But the elastin gives the skin its resilience, its ability to rebound, whereas collagen gives the skin its strength. So those are the two key structures, the two most important types of protein found in the dermis, collagen and elastin. If you look at cells, two of the key cells are the fibroblast and the macrophage. Now you know the fibroblast is the only cell in the body that can make connective tissue proteins that can repair or replace collagen. And you've got fibroblasts liberally scattered throughout the dermal layer, ready to carry out repair work whenever necessary. The macrophage is derived from the monocyte, and its primary responsibility is to control bacteria, to engulf and destroy bacteria, to break down any necrotic tissue. Macrophages and fibroblasts, the two most critical cells to wound healing. So you're going to hear about those cells over and over. Now what else do you have in the dermis? Well, you certainly have the cell bodies for those nerve endings. You have a rich network of blood vessels, which of course is important. It supplies the dermis and then that reproductive layer of the epidermis. And then you have structures known as epidermal appendages. And again, I'm going to go back because it's easier to appreciate in this slide. I want you to look at this hair follicle. And you know from reading different materials, they frequently talk about the pilosebaceous unit. And the pilosebaceous unit is the hair follicle and its associated oil-producing gland. Look at where the hair follicle sits. It sits in the very base of the dermal layer, just above the subcutaneous tissue. But also look at the lining for the hair follicle. Follow this reproductive layer of the epidermis and notice how it dips all the way into the dermis to line the hair follicle and that sebaceous gland. And that's why these structures are known as epidermal appendages. Because even though they're physically, anatomically located deep in the dermis, they're actually lined by the reproductive layer of the epidermis. So it's almost like they started out high and fell down and took that reproductive layer of the epidermis with them. Now I'm going to go back to something I mentioned a minute ago, and we'll come back to this again when we talk about wound staging and wound assessment. I want you to first imagine, let's see if I can figure out a way to show you this. I want you to first imagine that you have a wound and that the wound involves loss of the top layer of the epidermis. But this layer of the epidermis is left intact, that single reproductive layer. Then the entire surface of the wound is going to look bright red because right underneath that reproductive layer is a very rich network of blood vessels. But then I want you to imagine that you have a wound that involves loss of the entire epidermis and most of the dermis. And so when you're looking at the wound, what you're looking at is primarily collagen, and collagen is white. But scattered throughout that wound bed, you will have hair follicles. And everywhere you have a hair follicle, you'll have a little patch of that reproductive layer of the epidermis. So what you'll end up with is a wound bed that looks pale, but has distinct red epithelial islets. I-S-L-E-T-S, for those of you who don't speak Southern. And what that tells you is that your wound is confined to the dermal layer. It did not go through the dermis. It also tells you that your hair follicles are still intact, because every place that you see one of those little bright red patches, it represents a living hair follicle. We'll come back to that. Now, the last thing that you see on your handout, and this is a very important point, everything in the epidermis is capable of reproduction. You've been making skin your whole life, and you'll continue to do so until you die. Almost everything in the dermis is capable of reproduction. You can make more collagen. You can make more elastin. You can make more blood vessels. You can repair nerve endings. But you cannot make more hair follicles. You cannot make more oil-producing glands. You cannot make more sweat glands. So once a wound or tissue damage extends past the deep dermis into the subcutaneous tissue, you have moved from a zone that is capable of reproduction and restoration to a zone that is incapable of reproduction and has to be repaired through scar formation. And we're going to come back to this. Okay, now we're going on to the subcutaneous tissue, the fat. This is actually a very important tissue layer to skin and soft tissue health, but I always say this is a layer that gets no respect. Nobody ever says anything good about their fat. You never hear anybody say, you know, I really like my fat. I feel pretty good about it. I think I've got about the right amount. I love the way it covers my bony prominences and protects me when I have to slide across the seat. You never hear that, but it's true. Your fat plays a very important role in that it does help to evenly distribute pressures when you're sitting or lying on your bony prominences. Think about this. If you admitted 2 patients in one day and one patient was 30 pounds underweight and one patient was 30 pounds overweight, who would you worry about? And of course the answer is you would worry about the patient who's 30 pounds underweight because they have no way to self-protect. They're very, very high risk for breakdown. So bottom line, you'd rather have a little too much than not enough. Either end of the spectrum is where you're going to have major problems. Your patients who are very thin and your patients who are extremely heavy. You'd much rather have patients clustered around the midline where they're either normal weight or slightly overweight. Now the last thing on your handout, notice that the fat, the subcutaneous tissue, cannot regenerate. I know this goes contrary to what most of us secretly believe, that our fat cells reproduce at night. But we all know that fat cells are actually very much like bank accounts. You can add more fat to each cell, or you can withdraw fat from each cell. But the number of fat cells that you have was pretty much determined in your preschool years. And the only thing that changes it after that point is liposuction or tissue destruction. Now, the last layer we're going to talk about is the fascia muscle layer, which of course sits right next to the bone. The important thing about the fascia muscle layer, and specifically the muscle layer, is that our data to date indicate that out of all the skin and soft tissue layers, the muscle layer is the layer that's most vulnerable to tissue compression and to loss of blood flow. And that makes sense because the muscle layer has the highest metabolic rate. You think about the epidermis, very low metabolic rate because you only have one layer of reproducing cells. The dermis, primarily maintenance activities, nothing active. What about the fat? What does it have to do every day? What's on its to-do list? Hang out, sometimes literally. But the point is, nothing active in the way of metabolic activity. Compare that to the muscle layer, which maintains position, maintains tone, changes position. The muscle layer uses oxygen at a much faster rate than any other tissue layer, which means that's the layer that's most vulnerable if the tissues are compressed and blood flow is reduced. And all of our current data indicate that pressure ulcers actually start at the muscle-bone interface and then come up. Also think about the fact that the muscle layer is sitting right next to the bone. So when the tissue layers are compressed between, say, the bed and the bone is actually digging into the muscle, and you're going to get the greatest level of compression right there at the very level where you have the highest metabolic rate. So you want to think of the muscle layer as being the most vulnerable layer to ischemic changes and the point where pressure ulcers begin. Now, looking at functions of the skin, I just want you to know protection. That is by far the most important. Yes, it also plays a role in heat regulation. We've talked about sensory perception. Yes, you excrete sodium and chloride. But the critical thing that patients lose when they have massive skin loss is that protective barrier. So that's really what I want you to focus on. Now on your handout you have data about normal skin flora. That's just for reference material. Actually, most labs will tell you if you inadvertently retrieve skin flora instead of the pathogen you were looking for when you do a wound culture. If you come down to normal epidermal regeneration, I do want to talk about that. Now we've talked about the normal process or the normal lifespan of an epidermal cell. It said the cells are reproduced in that basement layer, they migrate upward, and by the time they get to the skin surface, they're very well prepared to be that waterproof, repellent shingle. They sit there for a period of time, they slough off and are replaced with cells from below. You know from taking care of patients and family members that infants and children heal very quickly and have very fresh looking skin. And you know that the elderly heal much more slowly and their skin looks old and tired. So what's the difference? Well, aging and illness prolong the period of time required to get new cells from that reproductive layer to the skin surface. So the reason that children and teens and people in their early 20s have such fresh looking skin is that cells migrate rapidly and they're always pushing those old cells off. So of course their skin looks fresh, it is fresh. The reason your older patients, their skin looks so old and tired, if you could go down and talk to the skin and talk to the little cells on the surface, and you said to them, so how long have you been here? They'd say, long time. So where's your replacements? I don't know. Thought he'd be here last week, not here yet. What's going on? The rate at which cells migrate, reproduce, and migrate slows down. So they're migrating very slowly toward the stratum corneum, that outer layer. And so the cells that you see have been sitting there a long time. There's a reason their skin looks tired. So if you look on your handout, you'll see that in general, it takes about 2 weeks from cells to migrate from that stratum germinativum, the reproductive layer, to the stratum corneum, the top layer. And then another 2 to 4 weeks to migrate through the stratum corneum and to be sloughed off. Now we're going to talk about changes that occur in skin physiology and skin anatomy throughout the lifespan, with implications for us as wound care nurses. We're going to spend most of our time talking about skin and soft tissue in the elderly because that's where most of our patients are. There's just a few other things I want to point out. So I'm going to go back, I hope. I see I left something out on the slide. So if you'll just look at your handout instead, what about fetal skin and fetal tissue? Well, that's not, taking care of patients in the second trimester of pregnancy is not something we're usually doing. But there's been some very interesting research because, as many of you know, we can now do surgery during the second trimester to correct life-threatening birth defects such as diaphragmatic hernia. And one of the interesting things they found is they would make an incision through the mother's abdominal wall, through the uterine wall, and through the baby's chest wall and abdominal wall. Do the repair, put the baby back, sew the uterus up, sew the abdominal wall up. At delivery, the mother's abdominal wall has a scar. The uterus has a scar. The baby does not have a scar. Very interesting, because what does that tell us? It tells us that there's something unique about either the cells and tissues during the second trimester of pregnancy or the intrauterine environment, or both, that leads to scarless healing. Interestingly, if surgery is delayed to the third trimester, typically those babies scar. And if anything's done after birth, they scar. So there's a lot of research looking at, well, what's different about the second trimester? And is there anything about that environment that we could capture and transfer into our wound management protocols or products. So just an interesting background point, nothing that we're going to ask you. What about neonatal skin? Yes, you want to know about neonatal skin. Many of you will end up working in settings where you're sometimes called to the neonatal intensive care unit, where you sometimes have to make recommendations for skin care, for wound care, for ostomy care. And so you want to know about major differences in neonatal skin. And the first thing you see on your handout is that in the neonate, the stratum corneum is much more permeable. Now let's talk first about term infants. Even a baby who is born at, say, 38 to 40 weeks gestation and is term has very immature stratum corneum at birth because that baby hasn't been exposed to the air, to the environment. He or she has been in an enclosed, protected, moist environment. Now, with exposure to air, the stratum corneum matures pretty rapidly. And so typically you see major changes that occur over the first 2 to 4 weeks following delivery. But during those first 2 to 4 weeks following delivery, you have to recognize that even in that term baby, the skin is very permeable, and that anything that we put on the surface of the skin can be absorbed into the bloodstream at the same rate as if we actually gave it IV. So that means we never use skin or wound care products on a neonate, a newborn, unless those products have been tested for safety in that population. Now, I can remember, because I've been in nursing a very long time, I can remember when it was standard practice to bathe babies after delivery and for the first few days of life with Visahex. And the thinking was that the hexachlorophene would reduce bacterial counts and reduce their risk of infection. But what happened was hexachlorophene got absorbed into the bloodstream. It was neurotoxic and it caused seizures. So of course this makes a lot of sense to me because I've actually seen it happen. Well, what about preemies? By 32 weeks of gestation, their skin is fairly normal, has developed fairly normally, and so then they'll go through those first 2 to 4 weeks where they're very vulnerable. But for your babies who are born at much earlier points, 26, 28 weeks of gestation, their skin is very immature. They're actually missing skin layers. They have very high transepidermal water loss values. They have very difficult time maintaining temperature. And they're even more vulnerable both to absorption of anything you place on their skin and to skin stripping. So then the last two things I wanted to point out is that neonates and prematures are much more vulnerable to infiltration injuries. Those of you who work with infants and neonates, those of you who have a NICU in your agency, you'll find that extravasation is one of the most common reasons for consults in the NICU population, and it's because they have two things that make them very high risk. They have very narrow, very thin-walled veins, so it's very easy to go through the vein when doing a venipuncture on these babies. And then the second thing is that the soft tissues are so distensible that it's very easy to miss and infiltrate until it's fairly well advanced. Now, most NICUs have very strict protocols about monitoring for infiltrates and extravasation. And those are very important protocols because these babies are so vulnerable. We'll come back and talk about management of extravasation injuries and infiltrations later in the course. And then the last thing I've already mentioned earlier, that newborns had not yet developed that interlocking configuration. So we know that prematures and neonates very high risk for skin tears. When you go to the NICU, you will see that those nurses are very aware of this. They very rarely use tape on these babies. They have all these creative ways of stabilizing lines and tubes without using tape. If you do have to tape, either for an elderly person or for an infant who has very fragile skin. You want to put down a protective dressing first, like a thin silicone adhesive dressing or a thin hydrocolloid dressing, and tape to that. Now, the big difference in infant skin, they still have higher risk of skin tears. They're also much more vulnerable to occipital pressure ulcers. But we're going to spend most of our time talking about changes in skin in the elderly and the things that make the elderly very high risk for skin breakdown and also very high risk for impaired healing. So I'm actually going to follow the lineup in your handout or on your Blackboard handout. I'm going to point out the things that are and are not pathologically significant. We've already talked about the fact that the elderly have thinner skin and that their skin has less barrier function. That's because their sebaceous glands don't produce oils at the normal rate, so they frequently do have gaps between their skin cells. Many times they are dehydrated, so their skin cells have shrunk. That means that it's very easy for irritants and pathogens to penetrate and to cause a skin infection and to cause candidiasis. Now, number two, collagen bundles in the dermis shrink. That causes the epidermis to wrinkle, not pathologically significant. Hurts your feelings, does not make you higher risk. But number three, we've already said, very important. The fact that the ridges and the dermal papillae flatten, so you lose that interlocking configuration. You end up with layers that just move against each other very readily. Means that these patients are very vulnerable to skin tears, and so you go to do a venipuncture, you go to stabilize the vein, you lift your finger, and you may have a flap. People go to help the patient out of bed, grasp their arms, may create skin tears. Number four, we've just talked about reduced activity of the sebaceous glands. Well, we've known forever that the elderly have drier skin. We know that means that they're at increased risk for itching and scratching, and of course that makes them vulnerable to invasion by bacteria and other organisms. But go back to that brick and mortar configuration. That reduced activity of the sebaceous glands is very significant because it means you have gaps between your cells. It means it's very important for us in providing routine care to routinely moisturize, to use products that will penetrate the stratum corneum, fill the gaps between the cells, maintain that barrier function, maintain elasticity of the skin. Erratic melanin production, not pathologically significant, but diminished numbers of sensory receptors, extremely significant. If any of you sustained an orthopedic injury, you were admitted to the hospital, you were put in traction, and let's say your heels were on the bed. At the point when your heels began to become ischemic, you would experience intense discomfort. And if you could not reposition your heel yourself, you would get somebody in there to do it for you. You would self-protect, either through your own actions or through enlisting help from others. But the elderly sustain a reduction in the number of sensory receptors. So even if that person's alert and oriented, he or she is not going to recognize ischemic changes promptly. And by the time they do recognize ischemic changes, it may be too late. So we have to help protect them. We have to keep their heels off the bed. We have to remind them to reposition. I remember one chart that I reviewed, and this lady had been in the hospital, orthopedic procedure. Then she had gone to rehab. About the second or third day in rehab, she said to the nurses, "My heels are sore." Well, when they looked at her heels, when they took off her TED stockings, what do you think they found? Purple, foggy heels that proceeded to be stage 4 pressure ulcers. But she did not sense ischemia in a timely manner. She was not able to self-protect. Loss of subcutaneous tissue we've talked about. You also get a reduction in immunocompetence of the skin. the Langerhans cells become much less active. And so that just means that you have a patient who's higher risk for skin infections. Look at 9, 10, and 11, all very significant to wound healing. Reduced blood flow to the skin increases the risk of pressure ulcer formation, also increases the risk of delayed healing. Cellular senescence, that is a huge issue in recent research looking at the wound healing process. You're probably aware of the definition of cellular senescence. It means that you have cells that are still living, but they are no longer reproducing and they're no longer carrying out critical functions. So they're basically taking up room, sucking up air, but doing nothing in return. You might work with people like that. And you know how frustrating it is to work with someone who's not doing their fair share. Well, if you have senescent fibroblasts, you may have a wound that absolutely does not granulate no matter what you do. So this is a critical element of research. Specifically, we need to be able to determine if we have senescent cells in the wound bed, if that's one of the reasons the wound is failing to heal. And more importantly, we need to know if we do have a significant number of senescent cells, can that be reversed? Is there anything we can do to take a senescent cell and restore normal productivity, normal reproductivity, so that they can reproduce and they can function? We don't know yet. Also look at number 11. There's evidence that in the elderly, wounds may get stuck in the inflammatory phase and may never cross over to the rebuilding granulation phase. And that's because from some evidence, it looks as if the elderly are prone to overproduce inflammatory mediators that keep the wound kind of stuck in that inflammatory phase. Also, we know that the blood vessels in our elderly patients are very fragile, so we're much more likely to see purpuric lesions. We know that bruising is very common. Okay, so the last thing I want to do in this little section is talk about measures to keep the skin healthy. And then we'll give you a break before we move forward. So what are the things we can do to keep the skin as resistant, as resilient as possible? Well, we want to look at our routine skincare protocols and practices and products. We should not be using bar soaps in general. The only bar soaps that are appropriate are soaps that contain moisturizers like Dove and Caress. Most bar soaps are fairly alkaline, which means that they alter the normal pH of the skin. In addition, alkaline soaps tend to strip away more of the skin oils and create more gaps between the cells. So look what's happened in the world of skin hygiene in general, never mind sick people. Look at all the products we now have access to. So I can remember when we all bathed with bar soaps, and I also remember having itchy winter skin. But now, hardly anyone bathes with a bar soap. Most of us bathe with shower gels, which are number 1, pH balanced. Number 2, contain moisturizers that replace lost lipids, lost skin oils. And most of us, if we compare how our skin feels in the winter now to how it felt during the winter, say 15, 20 years ago, we realize, you know what? All of those new products have made a big difference in how itchy my skin is. Well, when you recognize that itching is an indicator that the skin oils have been lost or stripped away, and that diminished itching is a marker for skin health, you realize that our new products that you and I use every day are based on science and make a difference in skin health. We definitely need to be passing that on to our patients. And I am betting that a lot of you now have bathing systems that are disposable soft cloths impregnated with pH balanced cleansers and with moisturizers, so that when you clean the skin, you leave it soft and moisturized. That is evidence-based bathing and very appropriate and something you want to advance. So basically, when you look at what's happening in your agency, What you do not want to see is hospital-based washcloths, which are like coarse-grade sandpaper, used with bar soap and delivered through the old bath basin, which is a petri dish. What you want to see is one of two things. Either the totally disposable bathing systems where you have the disposable cloths that are already impregnated with the cleansers and the moisturizers that you heat, you apply, and you discard. Or disposable bathing cloths are very soft baby-style washcloths and a pH-balanced, no-rinse, moisturizer containing cleansing product. Okay, so you want to make sure that what you're doing when you bathe your patients is keeping their skin healthy, because that maintains the barrier function. It's going to reduce their vulnerability to infections and to skin breakdown. Now, what about our tendency to use chlorhexidine gluconate impregnated bathing cloths for patients in ICU, and some LTACs do this as well. Also evidence-based, because we know that our ICU patients are very high risk for hospital-acquired infections, specifically line infections. And that goes back to high bacterial counts on the skin with very scary pathogens like VRE and MRSA. We also have good data that routine bathing with the CHG impregnated bathing system significantly reduces levels of pathogens and incidence of hospital-acquired infections. So it makes very good sense. Now, is this one of those situations where you have to do something that's bad for the skin in order to reduce the risk of infection? No. Those bathing systems, again, do use the appropriate soft cloths. In addition, you can continue to use moisturizers in patients who are being bathed with the CHG impregnated bathing system. It's a common myth that moisturizers are contraindicated and that they inactivate the CHG. But in actuality, there are many moisturizers on the market that are compatible with your CHG bathing systems. So what you want to do when you're talking to your vendors, if you're looking at obtaining a CHG bathing system, you want to identify which moisturizers can safely be used in conjunction with those products so that your patients get both things they need. They get bathing with an antibacterial product that significantly reduces the risk of hospital-acquired infections, and they also get routine application of a moisturizer that will keep their skin soft and supple and that maintains that barrier function. Now come down to moisturizers. I want to talk just briefly about the different types of moisturizers. You want to know these terms so that, again, you can talk to your vendors and you can look at what products you need for your patients, and you can teach your staff when to use what. Now, emollients are a component of all moisturizers. And emollients are products that penetrate the outer layer of the skin, fill the gaps between the skin cells, add softness and pliability to the skin. And your emollients are things like dimethicone, your different types of oils, lanolin. All good moisturizers include emollients. So everybody should get emollients on a routine basis. Now, I want to mention dimethicone specifically. We're going to come back and talk about that again when we talk about moisture barriers. Dimethicone is a component of many of our skincare products. It effectively penetrates, it fills the gap between the cells. It also creates just a thin film on top of the skin, as many of your moisturizing products do, and that film retards the rate of water loss. So it actually traps water in the skin cells to keep them soft and plump, fills the gaps to maintain the barrier function. And dimethicone also provides some degree of protection against urine and stool. So dimethicone is both a moisturizer and a moisture barrier, and we'll come back to that. Then you've got another whole set of products, and they're called humectants. Humectants are water attractors. And when you put a humectant on, it's going to actively attract any water in the product, water from surrounding tissue, pull water into the cells, and help to rehydrate the cells. So if you're using a humectant, you should be using it on very dry skin, xerosis. You would not use a humectant on overhydrated skin. So if you had a patient who was having multiple incontinent episodes, and you're thinking, I need to keep the skin soft and supple and resilient, and I need to be sure I'm replacing lost emollients so that I don't have gaps between my cells, you would use an emollient. But you would never use a humectant because it would pull more water into those already overhydrated cells. In contrast, if you have somebody with those very dry, scaly, cracked feet and legs, perfect place to use humectants. Classic humectants. A lot of you have seen dermatologists prescribe lac hydrin. Some of you have used Attractate. You might have used Aquaphor or Elta, which are very high-level emollients that significantly retard water loss. So you just want to think, what am I trying to do? If you're trying to keep the skin healthy and fill the gaps between cells, you use one of your standard emollient products. If you have very dry, cracked skin and you're trying to attract moisture, trap all moisture, then you're going to move more towards your humectant products. And then the last thing I wanted to mention is dry, scaly skin, like those very dry, cracked feet that you see in your diabetic patients. And I wanted to just pass on a couple of things you can do when you're dealing with very dry, cracked feet or legs. Vinegar water soaps can be very helpful. Now, you don't want to leave them in the vinegar water solution for a prolonged period of time. If they're diabetic, you definitely want to check the water temperature, and you definitely want to dry well between your toes when you get them out. But you can take either a bath basin and combine 1 part vinegar with 3 to 4 parts water, or you can soak a towel in that solution, wrap it around their legs, and then put a plastic bag over it. Leave it for about 15 minutes. Take it off, rinse their legs, their feet. Take a dry washcloth and lightly buff, and you'll be amazed at how much of that dry skin comes off. And it's because acetic acid or vinegar is a keratolytic, meaning it penetrates that dry skin, takes the water with it. So you could do those soaps 2 or 3 times a week. Use very heavy-duty emollients and humectants every day. And within a few days, or a few weeks, I should say, you know, they'll have skin instead of that alligator hide that they had there to begin with. So I just wanted you to know about that. I think we're going to stop there, and when we start back, we're going to go over dermatologic terminology, and then we're going to talk about some general issues in skin and wound care. Thank you.